Well, I think in particular in Hodgkin lymphoma we are making great steps forward in the sense that there is now, as you know, a new targeted agent that is being explored in many patients with Hodgkin lymphoma. That is an antibody, anti-CD30, linked to a cytostatic drug with a very strong linker. If that complex is injected, it will specifically bind to the malignant cells in Hodgkin lymphoma, the Reed-Sternberg cell that is CD30 positive. So the anti-CD30 hooks to the CD30. The Hodgkin cell internalizes the whole complex, including the cytostatic agent, and splits off the cytostatic agent and commits suicide. It's a Trojan horse that is introduced. And now at this meeting here at ASH in San Francisco, we see more and more data evolving from patients being treated in the first line, so trying to replace cytostatic drugs within the chemo regimen by Brentuximib vedotin, taking out the dangerous alkylating agents that may cause leukemia or secondary tumors later on, and still keeping a very high efficacy. Or coming in with Brentuximib vedotin a couple of cycles, then limited chemotherapy, and then if the PET becomes negative, the PET scan, you can most probably leave out additional radiotherapy, because in the early stage of Hodgkin's, so far we use combined modality treatment, chemo plus radiation, and now it might become Brentuximab vedotin plus limited chemo without radiation, which is of course to the benefit of, I think, 85% of patients that could do without. So exciting new data in the first line, but also in relapsing patients where Brentuximab vedotin is combined with chemotherapy to see whether you can induce again a PET negative complete remission prior to autologous transplantation, because that will, to my mind, predict a better cure rate in the second round in relapsing patients.